Let's welcome Dr. Chris LaGanke.
Thank you. Thank you, Stuart. Anybody feeling sleepy? Okay, my job is to have no one fall asleep after this meal. So anyway, hopefully this talk is going to be very educational. It's going to start with more sort of philosophical aims of treatment, and then talk about our current treatments and treatments that are going to be coming down the pike. And I have to remember to choke on this thing in order to get the volume up. So there's the topic. We're going to talk about treatments. And we need to know why we're here. You know, why did you show up today? Why did I show up today? Because MS is the #1 disabling neurological condition in the world for young and middle-aged adults. It's like a tornado in your central nervous system. It wreaks a lot of havoc. Okay, this is a tornado in our town, April 27th, a few years ago, on that day when there were 300 plus tornadoes around. And you can see right in the middle of town, it's having its way with us, just like MS can have its way untreated with a lot of us. MS is fatal. 7 years lost life untreated. This is a fatal condition, untreated. So that's the sobering facts of why we're here today. This isn't carpal tunnel in the hand. This is a very, very serious neurological condition. And fortunately, we have a lot to offer today that we didn't have to offer several decades ago. That's what happened. That was the aftermath. Downtown, that was a church. No longer. That's my mom. She died from this condition. So she died at 62 years of age because of MS. This is a fatal condition, untreated. She didn't have the benefits of treatment. The cutest person's the little one on the right over there, by the way, but just in case you didn't know. But it's kind of a hard thing when your mom's walking fine and you're walking with a cane. It's hard on the mom to see your daughter affected like that. And it's hard to bury your daughter, like it was for my grandmother. So you kind of saw a progression, young girl, then to a cane, and then my graduation at UNC in the 80s. She's in a wheelchair, and then she's gone. And you can see the brown there is the plaquing, the periventricular plaques from MS, and then you can see them scattered elsewhere. So we don't want that. And fortunately, we're in a day that we can treat that now. So here, for example, is a study looking at one of our interferons that actually prolonged life and restored normal life expectancy, 7 years regained life. So you can see the dark blue curve is one with treated, and the light blue is untreated, and proportion of patients still alive is the x-axis, or the y-axis, I'm sorry. Now I'm going to be on a soapbox from time to time, and this is one of them. Because we live in a world where we'd love to have evidence. We would love to have evidence for everything we do, but we don't have evidence for everything we do. It's something we strive for, but in the lack of good evidence, we have to use common sense, and we have to be an advocate for you. So you'll hear a lot of things. Well, that medication's not proven for fatigue. For example, Amanda talked about medication for fatigue. And just because it's not proven doesn't mean it doesn't work, and it doesn't help your quality of life. So we have to kind of go outside the box sometimes for our treatments to be an advocate, to get them approved, to then have them be a standard. And this goes very well hand in hand. So this is Sir William Osler, who recognized this over a century ago. So we can't put medicine into everybody follows the rule book exactly the same. Just like the alpha genomic testing. That looks at a person's enzymes. how you break down things and what your enzyme pattern is. Are you a fast metabolizer, a slow metabolizer, for pain medication, for fatigue, for whatnot? Well, it's a great bit of variability, and what works for Joe doesn't work for Mary. And the same with the pediatric question. So children's presentation of MS can be exactly the same, it can be different. Seizures may be slightly higher in kids, would be the only presenting symptom that maybe is a bit higher, I think, in children than in adults. We just heard about symptom management, the invisible symptoms. Right now, that dominates our discussions in clinic. Most of our conversations have to do, how can we improve your quality of life? How can we get you more energy, keep you from going to the bathroom, help your thinking, reduce your pain, help the spasticity and the MS hugs? How can we help you? That dominates our discussions because our treatments to slow down progression of disease have done fairly well overall. And it's all about quality of life. That's what the symptom management is about. And you saw these. So fatigue, cognition, neuropathic pain, bowel bladder sexual issues, and balance, motor, those are the biggies as far as symptoms go. As far as motor goes, that's the number one concern is, am I still gonna walk? If you ask questions different, for someone who's newly diagnosed, am I going to be able to continue to walk? And just a deviation for a minute, whoops, excuse me. This is a demyelinated segment along a nerve pathway in the central nervous system. And MS is demyelination or stripping of the insulation in the pathways in the central nervous system, brain, spinal cord. So here you see an area that's been damaged, and potassium channel is open and there's a lot of potassium spread. So the signal comes down and it shorts out in that area and you lose some of the signal. So you can see the dotted arrow that's going forward is not as strong as the arrow coming in. And that's part of the reason you have fatigue too. You're using a lot of energy moving those potassium ions out. Well, the signal shorts out and you don't have very good downstream function. There's a medication for motor problems and endurance problems called Empira that helps block the shorting out pathway so more signal can go forward. So we've had the good fortune of having some people who'd been in the wheelchair for several years who now walk just by taking this medication for symptoms. Just because that's all they needed was to improve signaling through that scar. It doesn't work for everybody, but that's a symptom management that has helped quite a bit for some people. So what's our goal with treatment? Now this is for disease-modifying treatment. These are medications to stop progression of disease, cut down relapses, come out MRI lesions. What's our goal? And I thought about this around 2000. I just, in a quiet moment, said, what are we trying to achieve? And I came up with a home run of therapy. Played baseball at UNC, so that kind of seemed logical to me. 4 things. And first is well tolerated. Because if we fix MS for the next 30, 40 years of your life and you feel lousy 1 or 2 days because of the treatment, that's not a win. So we need it to be well tolerated / safe. Number 2, no attacks. Now, attacks and pseudo-attacks need to be differentiated. So pseudo-attacks are old symptoms that come out when the body is stressed for some reason or another. Whether that be overheated, infection, psychological stress, whatever the case might be, symptoms worse, old symptoms coming out, that's a pseudo-attack. And yes, we'd like to stop that and treat that, but what I'm talking about here is new neurological deficits that you have for 24 hours. That's a relapse, an exacerbation, an attack. It all means the same thing. So we want no more new areas damaged that lead to physical dysfunction, which leads into the third one, no worsening on your exam. There are several patients, probably half or so, who come in and have a deficit they didn't know about. They didn't know their left side was weak. They didn't know that they didn't feel so well in this portion or the other. So we have to we have to do an exam. I'm still dumbfounded by some patients. Well, you examined me. And I said, what do you mean? They go, well, my last physician we talked. Oh, we don't know what the deficits are. We have to examine you. We have responsibilities. And then no MRI change. And that's important. And I'm going to talk about that in just a minute as well. But this is a home run. Well-tolerated treatment with no signs on physical exam by your history of relapses or an MRI of any disease progression. That's the bar we set for our treatments. And why? Well, this is a concept that came out in 2009. NIDA, no evidence of disease activity. So it's kind of the buzzword. And it's kind of part of my home run without the side effect part, without the tolerability part. No relapses, no disability progression, no MRI change. And this is what we're really striving for as far as super responders go in our clinical trials now. And one large study with 219 patients in early MS, called CIS, or relapsing remitting MS, this was looked at. And people who had achieved NIDA at 2 years, high percentage of patients had no change in their neurological condition at 7 years. So early control of the disease has a huge impact on long-term outcomes. And my kind of observation in clinic is if we can control MS for the first 2 years, we're golden most of the time. But you have responsibilities and I have responsibilities. Your responsibilities are to let me know if you're having side effects or problems with the medication, which puts you at risk of not taking your medication appropriately. And you're to tell me if you have a new neurological deficit lasting 24 hours or greater, a relapse. And my job is twofold: to examine you every so often and to do an MRI every so often. And as long as we do that and we've achieved control of your disease, we're in pretty good shape to control your disease. So what happens early? We have inflammatory activity, we have injury of the wiring underneath the insulation, we have loss of brain cells, atrophy, in both the gray matter, the outside part, and the white matter, and then relapses. And what you see in the left-hand side, in the white portion of this curve, is MRI activity occurs before we have that first blue bar, which is a relapse, an attack. And if this was really appropriate, there would be 9 arrows prior to that bar. So 90% of lesions in the brain don't cause symptoms, like paralysis or that MS hug or blindness in an eye. So we have a good bit of MRI activity, and that's leading to destruction in those neural pathways, which leads to atrophy and axon loss, and it occurs early. So we used to think MS is two-staged: inflammatory early and degenerative later. So relapsing remitting, secondary progressive. That it was all inflammation early and it was all subsequent damage or degeneration afterwards. But this would say differently. So this graph, 3 histograms, show that a person who has a lower disability score, so the EDSS scale for our disability is 0 to 10, 0 no symptoms, 10 death due to MS. So a 2 to 3 is kind of early in the scale. And we see a lot more axon damage early compared to placebo patients. So patients who had damage at that level had much higher levels of axon loss. And then the next compares the EDSS of a little more disabled population to the one prior, and so on down. So the last one compares itself to the one prior to it. So there's still more axon loss as we go on, but there's quite a bit early in the disease. And we can't really rewire at the present time. Hopefully, I'm going to talk about in a little way, we can maybe remyelinate soon, and that would reestablish the myelin. But if we lost the wire, I don't know how effective that's going to be. Atrophy. So this graph depicts patients who are active, having at least one active lesion in 6-month consecutive monthly MRI scans. At least one of those 6 had an active lesion, versus patients who didn't have any active lesions. And you can see the atrophy over just 18 months. And it was higher with the active patient who had active destruction, but you can see it's accumulating even in patients who did not have an active lesion on the MRI scan. There's still some atrophy. And that's a little greater than those of us in the audience who don't have MS. So patients with MS have atrophy 10 times greater than patients who don't have MS. And here you see that the blue bar is greater than the 0.1% per year that one would expect with normal aging. How about relapses? Early relapses predict conversion to secondary progressive MS. So the more relapses you have in the first 2 years, 28 years later, more likely you're going to be in secondary progressive MS. So controlling the disease early, very, very important. It's important at any stage. So even if you didn't have the good fortune of being treated early, still we can have a positive effect. But especially for those who are just diagnosed who say, well, I feel well, I got over my relapse, I don't have any symptoms left, I really don't want to take a shot, I don't want to take a pill, I don't want to take an infusion. Well, this ought to just resonate really strongly, that you're setting yourself up for bad long-term outcomes. Now, how about MRI activity? So the greater the MRI activity early, the more likely we're going to have problems down the road. So again, we want to shut that down. Here's a study that looked at MRI lesion load and what happens if you developed a new lesion in the first year of observation after treatment. You had a much higher likelihood of having sustained neurological deficit over time. And it's linear. If you had 2 new lesions, even greater in a linear fashion, and 3 lesions, even higher. So each lesion by itself, without any symptoms, predicted worse outcomes. So that's why it's a part of the home run of therapy. Because one might say, I'm on my treatment, I'm doing fine, I haven't had any relapses, I'm working, et cetera, et cetera. Why should we treat this MRI lesion that just occurred? Why should we consider changing therapy? Because of this, and 15 other studies like it, that new MRI activity predicts worse outcomes independent of whether you had a relapse or not. That's why we do those MRIs when you're not necessarily feeling any worse. So what's an appropriate treatment response? You go on a treatment, how do you know that's the right treatment a year, 2 years, 5 years later? There's no definition as to what an optimal treatment response is. Is 1 new lesion in 10 years, is that acceptable? Well, if you started out with 2 or 3, that's a different story than if you started out with 50 active lesions and now a few years later you only developed 1. That's maybe pretty good. It's all relative as to how active your disease was and how well the medication controlled it. So we don't really have a standard evidence-based that if you do this, then this is your outcome for sure. We have statistics, probabilities, but we don't have absolutes. So these are certain phrases that have been tossed out. Someone who doesn't respond at all, someone who doesn't respond as well as we think they should have, and then someone who just kind of fails this one treatment, they had an attack, and that would constitute a failure, maybe not just a non-responder overall. But patients who go on treatment, and this is a little bit dated, 2009, so the older treatments, a number of patients still had disability accumulate over time. So we need to start something and ensure that it's doing what we want it to do. So when a person has a relapse, should we treat it? Another question. There are 11,000 transected wires for every cubic millimeter of dye that we see on that scan representing an active lesion. So just one active lesion, 1 millimeter of an active lesion, 11,000 transected axons. That comes from Bruce Trapp's work from the Cleveland Clinic when he did biopsies of active lesions. So I would rather have more axons than less axons myself. So the longer inflammation goes on, the more likely we're going to transect more axons. Right? But we're not going to biopsy a patient serially and prove that. There's no evidence to that, but it certainly makes a lot of common sense that the longer you have toxic inflammation around, more likely you're going to damage more areas. IV steroids prior to oral steroids. There's an optic neuritis treatment trial, Patients took oral steroids. They had more attacks over time than those who took IV followed by oral, and they had more attacks than patients who weren't treated at all. So it seems like maybe taking oral steroids without an IV primer might set you up for future events. It did show that in one trial. So I would never give just oral steroids for an attack without giving at least a few-day primer of an IV. And then ACTH is a treatment. It was a treatment back when my mom was in the 70s, treated for an exacerbation. So you have to go in the hospital for a few weeks. She'd go to rehab. I'd see her 6 months later when she came home from devastating attack. So she'd get the ACTH. Well, then IV Solumedrol came around, and that cut out such lengthy hospital stays. So it got rid of the ACTH treatment, essentially. And now ACTH has come back with just a shot under the skin for 5 days, which you can do at home. So ACTH has reemerged as one of the treatments for a relapse. Very pricey, so it's not first-line agent. It's for those patients who have not tolerated steroids, have not benefited from steroids, or don't have any IV access at all. We need to monitor progress. Relapse management in this world is abysmal across the board. There's no standard. There's no proof of anything we do to treat relapses as far as length of time, what kind of follow-up, how do we make sure a person's done well with it? It just doesn't exist. And so some people are just treated, here, take some steroids, I'll see you in 3 months and we'll see what happens. Okay, for me, that's not good enough. And I wouldn't be able to go to court and say my way is better, but I believe in my way, so this is how I do it. I'll treat, let's say, with IV steroids and tell the patient, if you're not any better in a week, you need to call. If you initially get better and then decline, you need to call because the threshold has been breached as far as control of inflammation. And we probably need to go back up to a higher dose to control that inflammation. And then you need to come back in 6 weeks. I need to make sure that you've gotten all your function back. 3 months too long, sealed the deal, scars formed, not going to get it back. Okay, so we need to treat, we need to ensure the treatment's doing what we want it to do, and then we need to follow up shortly to make sure that we've taken care of this problem. So Acthar is the ACTH treatment. So if steroids don't work or aren't tolerated, we have the ACTH, which not only increases your own steroid production, but it also has direct binding on a lot of the key players in relapses. It also has direct binding in the brain, in the spinal cord, and in the optic nerve. So this is a viable alternative if steroids haven't worked or haven't been tolerated at all. So what happens if we don't treat relapses? So still today, taught in our universities is steroids don't do anything but shorten the time until you get back the function you would have gotten back anyway. That's how I was taught. That's how it's still taught. And it's taught based on a study in the late 60s and then another in the early 70s. And that wasn't the aim of the study. It was an observation as oh, by the way, I noticed this. The patients that we didn't treat for 8 weeks, then we treated with ACTH, they got better, and their scores improved for 2 months, and then by 3 months, everyone was about back to a baseline. Well, that study wouldn't hold today as any kind of valuable scientific endeavor. It was just an observation made, but it went as if it's sacrosanct, and it's taught as steroids. You don't need steroids because you're going to get back to the same place anyway. That's dangerous. That's not true. That's not been our experience whatsoever. Well, here's one study of two. There are two studies, Fred Lublin, the author of this study, and Bruce Hurst, another study, that shows permanent change in disability with a relapse. So here, 42%, the other study, a little higher. So between 40 and 50% of the time you have a relapse, you're going to be permanently different. Never walk the planet the same, figuratively. And that's a half a point. 30%, 1 point, greater bit of disability. So you have a third of a chance of having a significantly noticeable worsening neurological permanent status from a relapse. We don't want any relapses. So I hear it. Well, my doctor said that it was doing okay. My treatment was doing okay because I only had 1 or 2 relapses in the last couple of years. I used to have 3 or 4. That's not good enough this day and age. Not good enough. We should not tolerate relapses. We have one, we treat it aggressively, we talk about changing our treatment. These are some of the things that we as clinicians have to think about when we're talking about a treatment. So this is going on not really consciously. We're trying to assimilate all this, just kind of put it into our auto files and spit out, we think these are your best choices of treatment. But from a benefit standpoint, an efficacy standpoint, how is that medication done in studies to cut down the relapse rate, annualized relapse rate? How has it cut down neurological disability progression? What kind of effect does it have on MRI scan? And then are there problems in starting the medication? We have to get labs and EKG and eye exam, make sure we don't have a certain virus. If you have diabetes, you shouldn't get this. If you have hypertension, maybe there's a problem. If you're on these medications, maybe this medication is going to interact with it adversely. There are maintenance challenges. Can you get your labs done all the time? The medications, you already have fatigue. This might cause fatigue. You already have depression. This might cause depression, et cetera, et cetera. Safety and tolerability. So there are a lot of things that go into deciding on the medication initially, and there's a lot that goes into, do we need to change this medication and to what? It's a very complex, it's not, here are 3 videos, go watch them at home and tell me which one you want to go on. Still happens today. Happened in the 90s, and whoever had the best marketing won. It still happens today in some clinics. That's just not acceptable, in my opinion. So it all depends on your perspective. Where are you? What do you want out of treatment goals? What are you going to tolerate and risk taking? So here's a complicated cartoon of what happens when a T cell binds with an antigen-presenting cell, the chemical or molecule that stimulates or triggers MS. Okay, so a cell chews up a bacteria, let's say, or a virus, and it puts on its surface a portion of that virus and says, this is the holy grail that you're looking for. And the T cell comes and connects, and it says, okay, I'm going to make T cells that are going to go against this thing, so we don't have to be bothered with that virus again or that bacteria again. Unfortunately, there's also this other signal, this co-stimulatory signal that needs to be attached in order to say, this is foreign and this is not me. And there's a defect in that in MS where we forget not to attack things that are not us, or that are us, because we don't have that second binding. Because there are only 20 amino acids, and our immune system sees 3 at a time, 3 on that receptor. So a virus, a bacteria, they're going to share a sequence of 3 with a whole lot of us inside of us. So why don't we attack ourselves all the time? Because we must have that other binding. And when you're in your mom's womb, your body and immune system's figuring out who you are, so you say, well, I'm not attacking this. So this is going to not put a co-stimulatory binding signal, and you're not going to attack this sequence, because that's going to attack my myelin, or that's going to attack my pancreas, or that's going to attack my joint if I have rheumatoid arthritis. Not going to do it, okay? But there's a defect. And so there's lots of places to intervene as far as treatments for MS. Once this happens, where can we intervene? A lot to do. That Th0 cell, that T cell in your immune system that's ready to take action, take charge, is a Th0 cell. It's stimulated by that antigen-presenting cell, so it stimulates the naive cell. And it all depends on the environment as to how that T cell is going to turn out. It can turn into a Th17 cell, a Th1 cell, a Th2 cell, a T regulatory cell. And it all depends on what other chemicals and so on are there at that time. So can we influence what the chemistry is to kind of help hedge our bets to the right T cells, not the wrong T cells? And there's also some preliminary work that if a person genetically has a Th17 more genotype, that's their gene makeup, then maybe interferons don't work so well. And And if you have Th1, it works better than Copaxone. So we're trying to learn from genomics and genetics in a different way than what was discussed about symptoms on how we can tailor the right therapy right from the get-go and not have to do trial and error to get to the right medication. We tried to use risk factors to say, okay, you're playing this game a lot harder than somebody else, so you might want to accept some risks of your treatment because this is hardball right now. So if we identify very bad prognostic factors, things that are going to tell you have a high chance of not doing well in the future, you may be willing to accept some risk you wouldn't otherwise accept. So unfavorable prognostic factors: male, African American, multifocal presentation, meaning not just optic neuritis, but optic neuritis plus numbness, or weakness plus numbness, or balance, or vision, a combination. High lesion burden on the MRI, lots of lesions. If you have those, then you may be willing to play harder ball and say, I'm going to accept some issues because my chances of doing worse are greater, and it's all statistics. Okay, there's Susie who's 20, who has optic neuritis and 2 lesions. She can do very poorly. It doesn't get her out of the woods, but her chances of doing really poorly right off from the get-go is much less than a male who's 40, African American, with spinal cord lesions and not a lot of relief from their relapse, who has a lot of lesions in the brain as well. That person is predicted to not do well very soon, and we better treat that extremely seriously. So to the meat of the talk now. So what are the current treatments that we have? We have interferons. There are 5 different interferons, 6 different interferons now, or 6 interferons. Glatirimer acetate or Copaxone. 3 oral therapies and 3 infusible therapies. That's what's available to us at the present time. Interferons are better than they're perceived. The original study was tested in patients who had very, very active disease. I was at UAB at the time. We were one of the sites that was studying that initial population. I was a fellow looking at the spinal fluid. I wasn't managing them. I wasn't a neurologist at the time, but I was looking at their spinal fluid. And the patients who were chosen, because there was no treatment at the time, were those patients who were looking like they're headed south. We didn't want to give it to people who were very mild because we didn't know what this medicine was going to do. We didn't want to give it to the very advanced patients because we didn't think we could really exact a very noticeable change. If you're in the chair, you're in the chair. I don't think we're going to be able to see what kind of benefit. So these were the 30, 40-year-olds with lots of attacks. You can see physical disability. And they'd had disease for 9 years already. And thank the good Lord, this medication worked sufficiently to get approval. Now we see in the benefit study with high-dose, high-frequency beta-seron that 12 years later, if you start this medicine early, over 75% of people are still working and still taking their medicine. And quality of life indicators are 90%. No one would quote that in any kind of talk as a 33% reduction of attacks. That's the old data. Used early, they can be very, very effective. And I think, personally, I think high dose, high frequency is better than low dose, low frequency. That's my opinion. And they're safe. So we haven't seen PML, we haven't seen brain infections, we haven't seen cancers attributable to these now 22 years later. So they're very, very safe. So there's still a place for injectables for some people. I mean, common sense, if we had a needle and a pill and the pill worked just as well as the needle, I'm going for the pill, okay? But doesn't mean that needles aren't the right thing for some people. I had 3 in clinic this week, probably Thursday on one day. Been on a needle for between 10 and 15 years, no change in their disease. They're like, I'm not changing. Yeah, I'd rather have a pill than a shot, but I haven't had any worsening of my condition, and I don't have any funky side effects, and I don't have to worry about them. So I'm staying where I'm at. Yeah, it hurts a little bit. Yeah, I'm running out of sites. I hit a lump. I do this and that, but I'm sticking with this because it's working for me, and I can put up with that. Glatirimer acetate, also known as Copaxone. The standard treatment was daily shots. Now there's a 3-time-a-week version. Now there's a generic. It's the market leader. You have to be careful with that, though. Oh, I'm taking the one that's prescribed most commonly. It must be the best. Not necessarily. In a few studies, the reason why this is number one is because it's easier for the physician. No callbacks. We don't have to monitor labs. We don't have to worry about counseling a person about pregnancy, so it's real easy, so take this. I mean, I didn't go to med school for my ease and my comfort of lifestyle, I promise you. I went for you. I went to take care of you. So if it's more inconvenient for me to give you a better medication, so be it, I'm giving you the better medication. I'm not doing what's easier for my office staff and for me, right? Doesn't mean this medication isn't the home run for some people. It is. I have patients on all medications who are hitting those 4 cornerstones. But when you throw out statistics, this is the best, this is the market leader, you just have to be careful in interpreting that. Oral therapies, fingolimod or Gilenya, teriflunomide, Aubagio, dimethyl fumarate, or Tecfidera. So those are our 3 oral therapies that we have available. Gilenya, or the first one, has now been out 5 years, 3 years for teriflunomide, and coming up in the spring, 3 years with the Tecfidera. And they all have their place. So with Gilenya, for example, first one has the most experience. It's once a day. It's generally very well tolerated. You get through the first dose, the observation. It works very well. It works in patients who have very active disease. It cuts down the rebound that comes with coming off of Tisabri. Doesn't eliminate it, but it reduces the rebound where the shots have not been shown to reduce the rebound. Teriflunomide or Aubagio, it's the only medication we have in MS that has 2 phase 3 trials, the last trials before approval, that demonstrate a significant reduction in disability. Its effect on relapses wasn't so great, 30-something% like the original interferon trials. But the patients were also 9 years of disease. So again, a more advanced population, and it worked on cutting down significant disability progression compared to placebo. And Tecfidera, market leader of the orals, works very well for quite a number of patients. So they all have their place. We're glad to have them. Infusibles, mitoxantrone, called Novantrone, was the go-to when people were breaking through around 2000. It was a go-to treatment. Unfortunate, and we knew about heart failure that could occur with accumulation of this medication over time, so we had to ensure that an echocardiogram or a MUGA scan was fine before we would give the next dose. We knew that. We didn't know about leukemia. And leukemia occurred at estimates of 1 in every 150 who received it. So it's basically not given hardly at all in MS anymore. It's good for very aggressive disease when we don't have any other options and a person is willing to take a risk. Natalizumab or Tisabri, highly effective treatment, once a month antibody that's given. Has the problem with the JC virus and development of PML, or progressive multifocal leukoencephalopathy, which is a viral infection that goes to the brain and creates a lot of havoc. Fortunately, it's very uncommon, but still something we need to take note of in patients who are taking Tisabri. And then Alemtuzumab, or LEMTRADA, is our most recently approved medication, and this week we had, we gave it first in this country commercially a year ago, and this week we had 2 of our patients come back and receive their second round. So just starting the second round of treatment, and the other 4 who received it that first week are coming Monday. So all of them are going to get their second dose of this treatment. And so the LEMTRADA is a medication that's given 5 days IV, 1 year later, 3 days, and then hopefully the majority of people don't ever need to be treated again. So at this point, at the 5-year mark, between 60 and 70% of people have required no further treatment. after those first two. One of the things that this medication has shown now over 5 years is a significant impact on brain atrophy. So you can see here, the upper curve is a LEMTRADA treated patient, the lower curve is a Rebif treated patient. So this medicine was tested against Rebif, not against placebo. And we see a significant difference in brain atrophy, so preservation of brain. And now we go out 5 years, and we see a flattening of the curve. And we go out 5 years, and we see a real flattening of the curve. So in fact, that last year over here is better than normal aging as far as loss of brain tissue. I'm not going to promise that's going to stay. Years can be quirky and statistical. But you can see the trend is really a flattening towards normal brain atrophy. We've never seen that in MS before. We've never seen prevention of destruction and loss of brain tissue, except relapses or MRI lesions, but total brain volume. So very, very favorable, and these studies are going out over time. If we look at another concept that we didn't think about a whole lot in trials, reversal of neurological disability. This is improvement from your baseline, better than when you started. 33%, 43% in the two large phase 3 studies. So this is a sustained neurological benefit with exams separated by 6 months and at least a 1-point improvement on the 10-point disability scale. So this is a poster I presented in Barcelona in October of our first 152 patients in clinic treated with this medication. We now have between 300 and 350 patients treated with this medication. And you have to memorize this before you can leave, so you best get started. And no one's sleeping, so that's good still. All right, so I'm going to break that down a little bit into the nuts and bolts of that poster of what I presented. So this slide looks at patients, all the patients who were in the 152, and then those that we looked at with our EDSS. We didn't look at patients who are already using an assisted device or in a walker because there's very little movement on disability scales when we're there. Doesn't mean the medication is not effective or isn't helpful, but we generally don't see a person go from a wheelchair to walking unassisted, for example. So that's different. Patients who had had a 6-month MRI or a 4-month MRI, different numbers. But you can see that patients were largely female, largely Caucasian, largely JC virus antibody positive, and had a disability scale score of 3, which is really visible MS and close to heading down that slippery slope. And Tisabri as their last treatment, 110 out of 152. That was the main reason people go on this treatment. In our experience right now is that they want to get away from that JC virus issue and possibility of developing PML. So they want to switch to another highly effective medication. And what we saw was very little MS disease activity in our patients. So when we looked at new or active lesions, there were two. 2 patients one had a new lesion, one had an active lesion. 2 relapses, and 2 had a worsening of their disability score. That's it. 1 patient accounted for 1 in each column. They had a relapse with a lesion, and they were worse on their neurological exam. And then 3 other individual patients each had 1 of those. So there are a total of 4 patients who had some worsening out of the 152. And this is a population coming off Tisabri. And coming off a very potent medicine, we have seen some disastrous outcomes. So it's a 33% reactivation of disease coming off Tisabri. You have a 33% chance of having very bad rebound disease. And we saw none in the Tisabri patients. So those patients who had relapses, they were not coming off of Tisabri. So that's the first time we've seen a medication post-Tisabri that's eliminated that rebound activity. And in our experience so far, 42% of patients who'd gone at least 3 months post-LEMTRADA have had a neurological improvement. So already showing improvement early. And that's what this graph shows. Patients in the red bar are their follow-up visit, blue bar, first visit. So if you can see the first bar, EDSS of 0, there were a couple patients who had, actually there are 5 patients who had no signs of MS on their examination. And there wasn't a corresponding blue, so it wasn't just they had come from a disability upstream to get back on their second exam to a 0. And we've had several who have come in and say, I haven't had any MS symptoms for the first time in 15 years, or 12 years, or 10 years. That's a super response. That's not everybody. I don't want to say this is all sunshine and glory, okay? But there are patients who have had that kind of experience. So we have to balance that with safety and outcomes. So what were the things that we saw in patients during their infusion, during those 5 days? Well, we saw at least one elevated blood pressure reading, 89 patients. And then fast heart rate at least one time, headache, rash, nausea, vomiting. And then after, we've had a few patients who've gone to the ER with chest pain, and it ended up being reflux disease, most likely from the steroids that are given, 5 grams of Solu-Medrol before the Alemtuzumab. So some of these are related to the steroids. It's still a part of the treatment, so it still counts. It's still something that one can have as a side effect of the treatment itself. The cytokine release syndrome, the 5th from the bottom, is something that can occur where this medication binds lymphocytes, the surface of a T cell or B cell, kills the cell. Many are killed before you leave that first day. Well, some people, the chemicals are released in such a fashion that they have chills, they throw up, they feel their blood pressure is low, they feel awful that first dose. And it's a challenge to say, oh, come on back tomorrow for some more. But if they come back tomorrow for some more, they don't have any of those symptoms. And they don't have it the next day, the next day, the next day. It's an initial first day response called cytokine release. And we had 6 patients, I believe, 6 patients out of that bunch who experienced that. And fortunately, 5 of them came back the next day and the next day and the next day and the next day and didn't have any problems with it whatsoever after that. So I want to comment on the side there. So 6 patients went to the hospital, some for chest pain, as I said, had a couple of pneumonias. So prudence of taking care of patients who are maybe a little more frail, maybe the winter time's not the best time to give this treatment. Maybe the spring, summer for the ones who we think are a little more frail and could benefit from this treatment. Malaise, which is kind of feeling washed out. So we have about 20% for the first 3 months feel kind of washed out. Maybe their walking's not as good. They don't feel so well. They're not getting along as well. It's just the effects of getting over that kind of stress on the body. And the majority, vast majority of those patients get back up after that over a period of time. Some to the baseline, some better than the baseline. We haven't had, well, at that point, we had no autoimmunity. We haven't had any PML, and that's not a signal that's been seen ever with this treatment. We have had a case of ITP, or autoimmune platelet condition that's emerged now that we're actively treating. She's doing fine as of Thursday. And we're going to continue to monitor for some of the other side effects that might happen. Autoimmunity. I don't think I have a slide. Yeah. So there are 3 other things that we need to be worried about with this medication on the long haul. Number 1 is thyroid disease. 33% of patients develop either overactive or underactive thyroid and require a pill to slow it down or speed it up. The peak incidence is year 3, 2 years from the last dose. ITP, idiopathic thrombocytopenic purpura. That's an autoimmune attack against the platelets. Happens in 2% of patients. And after the first patient was identified in the clinical trials, everybody's been cured of it since then. There were 4 kidney cases, autoimmune attack on the kidney, all 4 doing well, not on dialysis or any immunosuppressant therapy. There were 4 cases of autoimmune cytopenia, or bone marrow suppression in one way or another. 3 of the 4 doing fine, no problems. One of them, who had an infection and bone marrow suppression, was controlled, infection taken care of, discharged home, refused to take antibiotic or steroid, and died. So that's the one bad outcome out of those. We have had an unfortunate outcome. We have had a patient who passed due to an infection, had gone to the hospital, had done well, went to rehab. She was in rehab and said, I feel my feet on the floor for the first time in 10 years. So despite going through that infection requiring hospitalization and quite sick with a low blood pressure and such, she was getting better. Developed another infection in the rehab and was given an antibiotic and had a seizure. And didn't really wake up all that well. Well, didn't wake up. And continued to seize without any evidence of it and fried her brain. And unfortunately, she ultimately passed. Such a sweet lady, such a bad outcome from an infection that we think, hopefully we are very keen to infections and treat them and other neurological issues. And I have one right at the present time who is on the ventilator with pneumonia. And she had called with a temperature, 102, about 2 weeks after treatment, no symptoms, no shortness of breath, no cough, no anything else. We said, well, watch very closely for the development of any kind of infection. Unfortunately, 6 days later, the husband called and said she can't even breathe. She's been going down the last several days. And by the time she went to the hospital, she had bilateral pneumonia. And so her prayers would be greatly requested from you for one of your colleagues with this condition who's fighting for her life at the present time. Again, due to an infection, so we have to be very vigilant with this treatment. We have to be vigilant for thyroid disease, for platelets, for kidney. We check labs every month for 5 years after your first dose or 4 years after your last dose. And that's for your safety. It's not for me to have extra things to do of paperwork. It's for you so that you don't sabotage the great effects of this medication because of a side effect that we could have treated. Okay? This cohort, the largest in the world, treated with this medication, we saw a significant benefit in the majority of patients. Many of them coming off Tisabri did not have rebound. Serious adverse events like influenza, pneumonia, we have to be aware of. Shingles can occur. And then a lowering of the white count, we have to be very vigilant on this treatment to make sure that we get all the good and if we have any kind of bad, we're going to treat it quickly and get rid of it. All right, so our treatment options now for primary progressive MS. None. Very frustrating. We don't have any treatments for primary progressive MS. That's about 10% of our patients who have MS. So then I'm going to go in the pipeline. So this is a chemical that's kind of Gilenya-like, SP1 modulator, S1P1 modulator, had a significant benefit on attack rate, on active lesions, on atrophy, some headaches, some runny nose kind of thing as far as side effects go. But this is an early trial. We may have a very good, another option here down the road. MINOCYCLINE, antibiotic for acne, all right, tetracycline, minocycline. Well, it was tested in 140 patients with early MS and a 46% relative risk reduction in attacks compared to the placebo. If you take an antibiotic and treat your MS, that's good. That's a pill and something that's well known for a long period of time. So this is going forward in study. OCRELIZUMAB. So this is an antibody like Tisabri and LEMTRADA against a certain receptor on cells, on immune cells. There were 2 studies, OPERA-1 and OPERA-2, that involved 1,600 patients, and we saw a significant, very marked reduction in attacks, disability progression, and MRI progression with very little side effects. This is an IV administered twice yearly. So this caught the storm in Barcelona. This was the RAGE discussion medication at the meeting just a month and a half ago. Okay, I'm going to come back to that one. Anti-LINGO. So we were blessed to be the #1 site in the Western world to enroll patients in this study, which is the first human remyelinating agent to hit a 2B trial status. This medicine was tested in optic neuritis in the RENEW study, and there was improvement. So the first time ever we've shown functional human remyelination with a medication. This was given in 6 monthly treatments. So we saw an improvement in visual acuity in people who had optic neuritis. And we saw improvement in the other eye as a follow-up in the Barcelona meeting. So this medication has shown repair of optic nerve demyelination and improved function. Now the Synergy trial is the one that we're involved in with MS. And that trial is wrapping up. And the first quarter of this upcoming year, we should have the results as to whether we have a medicine that might fix some of the plaques that are damaged in MS. So we may have evidence of remyelination in MS coming up in several months. And at least one person in the audience has received that as part of the clinical trial in our center. Stem cell transplant, 50% of people progression-free in 5 years in a recent study in Europe of very advanced MS, a very bad MS. 50% just kiboshed any kind of progression. And there are a lot of different stem cell treatments studies going around. You have to be very careful because there's some mom and pop, oh, we'll give you stem cells around the corner. Really in the western part of this country and down south in Central America and over in Asia. You don't know what you're getting. We don't know what the right dose, how many. Too many may crowd the brain and cause a problem. Too little won't work, and you've just spent $20,000 with the hope that you're going to get better. And I understand that. I understand desperate situations sometimes require desperate endeavors. But I would just implore prudence and that many trials are going on, and hopefully we'll have some of that evidence that this medication or this treatment given this way is helpful to you. Biotin, we recommend this for hair growth for a lot of our patients who have hair loss on one of their treatments or another. But it's a key enzyme in myelin synthesis. And a study in progressive MS had a positive result, preliminary study. So something as easy as a GNC product may do well in some people with progressive MS. So this is being studied further at the present time. LAQUINIMOD is going through its 3rd phase 3 study. The extension of the earlier studies show a durable effect, so we may have another oral medication available for relapsing disease. It also had a positive effect on disability. Daclizumab will be either the next or the second medication to be approved from here. It's a monoclonal antibody like the others, but this is given subcutaneous, shot under the skin once a month, and it had very favorable results in study. So this is a once-a-month shot that works very well with some side effects, local skin reactions, et cetera, but by and large, pretty good. So what do we do? What do we choose when you come in the office? It's not so easy. We have that perspective. We have many choices. We're going to have many more choices coming up. But we're glad to have a choice, because in my mom's lifetime, no choices when she could receive medication with relapsing MS. Just a word on secondary progressive disease. So the B cells sometimes can do that meningeal germinal center that you see in the center top. That's like a lymph node in the brain that keeps producing bad antibodies. So it gets behind the blood-brain barrier, behind the iron curtain. And maybe that's why secondary progressive is very difficult to treat, because those antibodies are liberated and our treatments are working on this side of the iron curtain. So that's one of the phenomena that we see with the B cell portion of MS. Now, is secondary progressive really a different condition or not? We hope to eliminate that term from our vocabulary because it's pejorative. It says you got progressive disease. That's bad. Makes you feel bad. And it's not about making you feel good, but is there really any evidence behind this being something different? This is really you chip away or you fray a pathway, and over time it's going to wear out. And we don't have anything right now that stops the wearing out. So you can have some progression of an old deficit. But that doesn't mean stop new things from happening, which will guess do what in 8 years? Wear out. So you're in a chair, then you're going to lose your arms and lose your thinking. That's not what we need to be doing for you. So we still need to work on how to stop the unraveling of old lesions, but it doesn't mean abort all treatment and allow you to accumulate new ones that are going to do the same thing down the road. Primary progressive, as I said, treatment options. only 5 to 10% of the cases. There's new criteria that have been developed this year, active, inactive, et cetera. There's a new way to rate it. The rate of disability goes a little bit quicker than other progressive conditions. 90% begin with walking problems, no visual sensory problems. There are not a lot of lesions with primary progressive disease. It's kind of stymieing how someone can become progressively disabled and not have a lot of lesions like in relapsing remitting. There are more in the spinal cord though, and those are very disabling. It's usually more males 50 years old are diagnosed with this than any other epoch. But like I said, there was a medicine that was the rage in Barcelona, and remember that OCRELIZUMAB, OPERA-1, OPERA-2 studies. Oratorio study was performed 732 patients, and for the first time ever, we had a medication that helped people with primary progressive MS. Got a standing ovation from our very nerdy colleagues who don't get excited about a whole lot. They have a bow tie, and if it moves, they get maybe excited about that. But they stood up, and this has been such an area that is unmet need that we're really excited that hopefully this year we'll have this approved and be able to treat people with primary progressive disease. Just a little bit of a warning, if it's really advanced, I don't know how well it's going to work. And those people are so excited to have something. I don't want to dash that, but especially for people with early primary progressive disease, this is going to be hopefully very, very good for them. And just a couple more if you bear with me. No one slept yet, so that's good. I'm achieving that goal. Just other practical points. Smoking's been associated with relapses and worse outcomes. And it's easy to say stop smoking, it takes work. But if you say I'm damaging myself, not only my lungs and risk for stroke and heart attack, but my MS as well, maybe that's enough to say we need to work on this. Exercise, as was talked about in the last talk, it's a marathon, not a race. So just 5 minutes of boxing if you're in a chair or walking to the mailbox and back, you know, raise a sweat, get your pulse rate up, you're like, that's a piece of cake. Fine. Dedicate yourself to that for 2 weeks, then go to 6 minutes. Then go to 7, or if you start with 10, go to 11. Get up to 30 minutes, 3 to 4 days a week, and it's going to help you in a lot of ways. It's going to help. But start out slow. Don't get discouraged by, oh, I went out and then I wiped myself out and I couldn't do anything for the next 2 days. I'm not going to do that. Start out really slow. This has long-term achievements. It's not getting there tomorrow. It's getting there for good, okay? UV exposure for vitamin D, just 10 minutes down here in the prime time, probably March or April through October. Very good for natural replenishment of your vitamin D. Cooling vests in the heat, very good, very effective, can allow you to function when you have to go out in the heat. Less carbs, as was talked about. We need family members to be educated. Well, you don't look like you have any problems, the invisible symptoms. And we all make judgments, we have to. We can't interview everybody, how are you feeling today? We make judgments by looking at people, and we look at you and you look fine, you don't look fatigued, but you're really fatigued. We need to be educated if we're family members. So we don't make judgments. Oh, you just don't want to go. And that leads to disastrous marital relationships and other relationships. So we don't need that. We need education and understanding. And we need you to have power in saying, I'm going to do my best. I'm going to have no relapses, no new MRI. I'm going to take my medication. If I have a problem, I'm going to let my healthcare provider know we are going to work hard to limit any advancement of this disease. Challenges, finding a blood test or a urine test we can monitor for effectiveness of treatment or diagnosis in the first place. We need to make sure that our benefits aren't at the expense of toxicity. So we need to continue to get high efficacious medications with little toxicity, or strive for little toxicity. We need to do better treating the symptoms, especially fatigue. It's the #1 disabling symptom and the #1 disabling neurological condition in young and middle-aged adults. #1 reason people get on disability, fatigue. It's not trivial. We need better treatments and more treatments for progressive forms. We need to improve our genetic classification so we can tailor treatments to your genes. Of course, we need to find the cause. That would be the holy grail at figuring out how to best treat this. And then we need to figure out how to assess your cognition. We do not have good tests to assess cognition. And that's a good portion of your frontal lobe. Large portion of that brain is cognitive. And we don't have good tests to reliably, based on your education, based on other things, based on your language, your ability to move your arms, et cetera. We don't have good tests to quickly assess your cognition. So we need to do that. Take-home point, this is a serious condition. Untreated, it can take your life, shorter than when it should be gone. We need to hold a high bar of success for treatments. We need to not just be lazy, here you go, and I'll see you back, and you just show up and don't let us know when things are going south. We need to treat relapses aggressively. We need to manage symptoms as if we had them. What if I had fatigue? What if I had sexual dysfunction? What if I peed on myself? What if I got up 5 times in the night? We need to take that seriously. That's your quality of life. That's your day-to-day living. And we need to treat everyone individually. Not everybody behaves the same way to any particular treatment. We need to take the individual, say, these are the statistics, but we're willing to change if things change. So I'm done. I want to thank my mentor, Dr. John Whitaker at UAB, who taught me so much, my mom who taught me so much, my staff. I couldn't do what I do without both my clinical and research staff. My parents, my children and wife put up with so much time away. And of course, ultimately, thank God, because nothing's possible without him. Anything I do well is his. It's all about him, and we need to remember that. So thank you very much. I'll entertain questions.
Thank you. Thank you. Thank you. So for those that didn't raise their hand when I first asked, now what do you think? He's just good? I think he's better than just good. Who's got questions? Ken's going to go on that side. I'm going to go on this side. I know we're going to have some questions here, right? Ken, you got that side of the room.
Oh, Jesus. After LEMTRADA, how long should the person expect to have flushing?
Still have flushing? Flushing? Yeah, flushing up to a month. You can have, it's usually a sporadic rash. Comes for a few hours, goes away, comes back. It's a very effervescent rash, headache. A lot of these symptoms, joint pains, they come and go when they come post, but after a month, really should be seeing that go away. We've had a couple, maybe 2 patients who had some kind of persistent weird rash. Fortunately, saw one this week and that's gone. But flushing, not too long.
Over here.
I have 2 questions. You mentioned the thing if you haven't taken anything or something like that, MS is fatal. What if, like when I'd say the first 20 years I had MS, there wasn't anything, but then after that I was on things for the rest, and I still am. So what does that do?
So good question, unknown. I would think that since you went on some treatment, the natural history is you'll lose 7 years untreated. So at some point you intervened and received a treatment. We don't know what those statistics look like, but my prediction would be that you have preserved years of life by going on treatment. I can't say fully, but I think you're still upright, which is one big thing, because it's when a person loses that and is prone to infection or blood clots and so on, those are the things that lead to termination of life.
Yes, on the LEMTRADA, there's all kinds of testing that has to be done. You have to be approved to take it. What's the approval? What is the approval time? What is it? I guess what are they looking for in the approval?
Different for different insurance companies, but they generally say you have to have had 2 prior treatments before you can have access to this treatment. And approval has been much, much better as the years gone on. So we've had much better success. And we got Medicare to give a permanent code, which helps open that up. And Medicaid had just decided within the last 2 weeks that they're going to approve the treatment. And the commercial insurers have progressively gotten better and better and better at covering the medication.
I've got a couple of questions real quick that was written. How long do you recommend going off beta-seron before and after surgery to help prevent infections? And then also, is it possible to have no lesions on an MRI but still have MS?
So first question, you really don't have to go off interferons with surgery. They don't lead to an increase in infection risk. They're actually produced in response to help mitigate the flu. That's how it all started with interferons. It interferes with viral replication. So you don't have to go off, but you're generally going to make interferon after the surgery. Just like if you had the flu, we say you can hold your treatment for a little while after because you're naturally producing more interferon. So it's not that you have to from an infection standpoint, but after a major surgery, depending on what the quoted healing time is, you might go off for a little while because that's kind of reduplication of the interferon. The second question, yes, you can have MS without any lesions. That's full of possibilities. One is that the scan was not a very strong scan, so an open MRI scan is 1/10 as strong as our strongest commercially available scan. So if you had, and we had a patient who had optic neuritis, went for a scan, had a brain scan, referred by the ophthalmologist, no lesions. I looked at it, there was at least one, maybe two. So that's the second thing, the radiologist may misread it. But they had an open MRI. We got a spine MRI, so we were able to throw in a freebie brain 1 sequence, and she had 10 lesions on her MRI. So it was 0 on the open, 10 on the very high-powered MRI. So it may be MRI, it may be what you image. If you image the brain and actually the lesions are in the spinal cord, you may see no lesions in the brain, but there's MS in the spinal cord along with the optic neuritis or something else that's going on. So yes, you can have it without, it's not very common. Most of the time, there are going to be lesions that are identified with the diagnosis.
With the interferons like beta-seron, are there any indications with long-term use that the body builds up a tolerance and it may need to have to increase the dosage over time?
There's, with the interferons, there's not any tolerance that we know of on the long haul. About 2 years, 2 to 4 years, a person can develop neutralizing antibodies, where you develop antibodies against the vital portion of the interferon, and it doesn't work as well. Increasing the dose isn't going to change that. It's not going to work very well. Just by having neutralizing antibodies doesn't mean that you're going to have a bad response. If you have a very high neutralizing antibody level, that's been associated with worsening disease. So if someone seems to be breaking through, we test a neutralizing antibody. If it's very high, we'd say interferons are not going to work for you. Okay, but changing the dose hasn't been seen to do anything if a person starts having attacks while on it. More commonly, we'll see people who get sloppy with their injections. So they start missing some, then have disease recurrence. So in your case, increasing the dose to normal would maybe help that person. But if someone's taking them regularly, having disease activity, unlikely that changing the dose is going to have a change in outcome.
If you've been on Tecfidera for a while, I heard you say earlier that you had to have 2 treatments prior to LEMTRADA or whatever. Is that correct? Yes. Well, we're thinking about, well, she's just been on Tecfidera for about 3 years, and it doesn't seem like it's doing much, or, you know, as far as I can tell. Should she go to something else before LEMTRADA or whatever?
Well, number one, I think no matter what the agent, and it can be any agent, and people have failed all agents. If someone's not hitting the home run, we're talking about changing treatment. So if we're not doing well, we're having more disease activity. If we're having it, we're talking about switching. So regardless to what someone's having is violating that home run, we're at least discussing changing therapy. As far as getting on LEMTRADA with only 1 failed therapy, we have had a couple successes in individual cases for particular reasons, but by and large, the insurance companies hold the line and say you have to fail 2. So number one, if you're not doing well on any treatment, I'd recommend going to another treatment. If you haven't had 2 yet, it's going to be difficult to get LEMTRADA as the second agent.
Is an attack, when you have a new attack that's brand new, symptoms, everything, does that mean you've got a new lesion? And the pseudo attacks, are they really attacks?
So if you have a new deficit, a new neurological deficit lasting 24 hours, and we don't see another cause, some other reason, and we don't see a lesion, we presume there is a lesion, we just weren't able to see it. okay? Now, we just have to be mindful that you're not immune to other things. Like was said, if you have fleas, you can also get ticks. So you can develop B12 deficiency, thyroid disease. You can develop other things that happen that can cause some neurological deficit. It's not MS. If we exclude that, someone has a new onset of a paralysis, it's not a stroke, then we're going to presume that that's a relapse and treat it as such. And the second question was?
Are the pseudo?
Oh, pseudo attacks. Yes,
Yeah.
I'm sorry. So pseudo attacks are not attacks. They're just a reactivation of old symptoms. It's kind of like the weak link feels the effects of stress. So if you have a scarred area, when you get stressed, you're not going to be able to transmit through it very well, and you're going to feel those symptoms. But once that stressor's gone, the symptoms should return, it should go away, and you get back to your baseline.
Okay, we have only about 20 minutes left because then the doctor needs to get out of here, so keep going.
Well, in the study, if I remember correctly, I wasn't a part of the study, I want to say it was up to 150 to 300, somewhere in that range is what they used in this study. I may be wrong though, so I'd have to double check that. And it should be online. We can put Biotin for MS, and it should give you the dose that was given in that study. It's preliminary at this point, but hopefully that's going to have some positive effect because it's a very well-tolerated, safe treatment.
Anyone who has been treated with LEMTRADA, is there any reason for another medication to be precluded, like an anti-LINGO or a stem cell?
So with LEMTRADA, just for relapsing disease, to this point in the studies, only 5% of people have gone on to a different treatment at the end of the day. So very high retention rate. You might require a third course or a fourth course at some point down the road if you think that the first two were helpful in some way. But I presented in Philadelphia a couple years ago at the American Academy of Neurology meeting all the patients who had gone on other things, and every other medicine has been used post-LEMTRADA in a safe fashion. So you can go to an injectable and oral, you can go to Tisabri, and it's been done successfully. As far as anti-LINGO or stem cell remyelination, there should be no reason that one shouldn't be able to get that. So if LEMTRADA cools down the relapsing disease, and you have some disabilities or symptoms still from the old scars, and a medicine becomes available to possibly fix those scars, there would be no reason you wouldn't be able to get those treatments as well.
Yes. I have a question. The thing about the medical marijuana, is that good for MS?
It's good, and as far as studies go, where you're kind of limited, again, evidence-based medicine sort of thing. We have people who say, well, I smoked and this happened and so on. So we kind of keep our ears open. I think more than likely it's helpful for spasticity, it's helpful for pain, and it's helpful for nausea that may be associated with MS. I think those are pretty well accepted as far as things that might be helped by marijuana. Other than that, it's a highly debated situation. I don't think there's enough evidence to clearly say it does this with MS or that with MS at this point. It's being studied quite a bit, especially in Europe. And there are some new ones that were presented at the meeting, new cannabinoid or marijuana-like agents that don't go to the brain cognitive areas. So very exciting that it has no effect on apathy or interest or other things, but just works directly on the areas that might be affected by MS. So there are a couple that are being tested far into studies now. So we're excited about that because we don't want to affect cognition and fatigue. If we help something else, we'd like to help those things and not mess up other areas of the brain function if we can help it. So it's an area of hot interest, debate, and hopefully we're going to get some good studies prove yes, no, this is helpful. I really think it helps some symptoms related to MS. I just don't know if it helps the progression of the disease at all.
What is biomarkers?
I'm sorry, a biomarker is something that you can test biologically, like blood, urine, MRI scan, some visual evoke test, some test that'll allow us to determine the effectiveness of the treatment. So we can say, well, your blood test says that you're doing well with this treatment, or the urine test says you're not having any silent disease activity. The MRI shows that you're not having any progression of disease. And a biomarker also could be used to diagnose. So it'd be great if we had a blood test to say you have MS, you don't have MS, like we do with lupus or some other things. So a biomarker can be helpful in that way. So it can assess the effect of a treatment, and it can help us to make a diagnosis or not.
With LEMTRADA, you mentioned that shingles very briefly. If someone who has had shingles several times, does that mean it's just totally ruled out?
No. Shingles occurred at a higher incidence in the trials compared to rebif by a good bit, like 20% to 2, something along those lines. And so in the middle of the trials, a policy was instituted to give an antiviral, a shingles preventative pill. And when that was done, it reduced the incidence of shingles to baseline. So what's recommended is to take an antiviral for the first couple months of each infusion cycle of LEMTRADA. Now, like I said, evidence-based medicine is that, how many people did they test who had recurrent shingles going in? Probably not many, so we don't have any evidence. So we individually treat, and we'd say, probably stay on a preventative throughout the year, and then throughout the second year, take a once daily anti-shingles treatment to prevent the possibility of getting shingles if you've had it several times. That's not FDA approved, that's not anywhere noted, but that would be a way to individualize treatment and allow you to get the treatment without harming you.
Can MS and spina bifida be like highly linked together?
Say that once again.
Like MS and spina bifida.
Yeah, I haven't seen any links at all with spina bifida and MS at this point. I haven't seen anything. If there's any small study, I'm unaware of it. So no.
All right. There's a question that somebody's asking. They want to know if MS hampers orthopedic surgery recovery.
It depends. If the MS involvement is in the limb that's being operated upon or downstream from the spine, then it's not going to directly, just by the fact you have MS, you're not going to recover well. It's more that if it's out of shape, if it's hard to work it out, it's going to take longer to get better. But just by having MS doesn't mean you're not going to have the same outcome as someone else who has that orthopedic procedure, unless you have absolutely no function in that limb to begin with, or it's severely compromised. But it may take longer to get back, but it shouldn't keep you from the same outcome.
Ken, go.
Have you had any diagnosis of patients with burnout? And if so, how would you proceed with the next phase?
So burnout is when patients who've had disease for a long time stop getting new lesions or MRIs stable, and you think the disease itself has burned itself out and it's not really cause any more problems. It's reached its peak, it's done its thing, and it's done. That was a concept in the 90s that was talked about a lot. And that question was asked recently. Well, so 60, 70, 80-year-olds come in and say, I've been on this medicine for 10 years. I haven't had any disease activity. Can I just stop my shots, please? Because I think maybe the disease is burned out. There's been no MRI activity. That study was recently undertaken by Dr. Kistler, headed it up out of NYU, looking at that issue. Patients who hadn't had any disease for quite some time, who were more older in years and had been on a therapy for a while, stopped their therapy. Over 50% relapsed. 80-year-olds with relapses, etc., which would say, that's kind of risky. Even though you're doing great, you're not having any problems. It seemed like it was burned out. It didn't in the majority of patients. It came back again. So that's one study through many different centers. And so I think that begs the question for that to be looked at even further. Because I don't want anybody to take a treatment if they don't need it anymore. I don't want to just give a potential of side effects and toxicity if you don't need it. It's not doing anything for you. So we would love to be able to predict that. We might get a biomarker in some of the patients who did not have recurrence. What was it about them? Is there something that we can say, okay, well, you have a good likelihood of not having recurrence if you have X, Y, or Z. So it's being looked at actively. It's a very good question. We would love to not overtreat if we don't need to, but we certainly don't want to lead to new permanent neurological deficits in people either.
Somebody would like to know if you can recommend a neurologist who specializes MS here in Mobile.
To my knowledge, there's not a fellowship-trained MS specialist in this area. Dr. Eckstein unfortunately moved on to Duke.
Epstein's gone, they said.
From here, so he's up in Durham. I think a few people have taking care of a number of people with MS, but I don't know offhand of someone who's fellowship trained in that.
Okay, any other questions? Oh, here we go.
My wife passed away in July. I'd like to hear more comments about purpura. You mentioned it briefly as one of the side effects of a drug, and her mother also had that problem. So I just want to hear what you might have to say about it.
Okay, so purpura is the rash portion that occurs in relation to the platelet problem. There's ITP and TTP, and ITP is the condition that's associated with the LEMTRADA treatment, 2% of patients developing ITP. TTP has not been associated with it. There's childhood forms and adult forms of ITP. The childhood form is generally cured. The patient gets over the ITP, they don't have it again. Adults have a recurrent pattern. Fortunately, this medication looks like it induces a pediatric kind as far as not having recurrent ITP. To this point, that's what we know. As far as purpura and MS otherwise, I don't know of any strong relationship. When you have an autoimmune condition, you are prone to have another autoimmune problem. So it may be that they were linked with a common gene somewhere down the line. But purpura by itself is not felt to be related much to MS.
Is it treatable?
It is, in adults it's going to be manageable. All right, it's going to be something that you may have to have continuous treatment or recurrent treatments for it. You just have to stay on top of it and monitor it to see if it's starting to come back and intervene as soon as you can with it.
Okay, we only have time for 2 more questions. I'm going to take one. Ken's going to take one.
I just want to, if possible, get a copy of the PowerPoints.
They'll be on our website.
On the website? Okay. And then do you know, from your PowerPoint, you said that you're going to release the study in January. Is it possible for patients to get the study before it's released, like their results from the study?
No, because I won't get it before it's released either. So we won't have access to all of the different sites' cumulative study results until it's presented by the manufacturer. But I know that's going to be a huge, and I would almost predict that's going to be presented at the American Academy meeting in Vancouver in April, is probably when we're going to hear about it.
Before I go to the last question, I just want to let everybody know, whoever's leaving, please remember to fill out those seminar evaluation forms and leave them outside, please. We do need that so we could do future programs.
Really quick, my question is similar to the gentleman right here. My husband's been on Tysabri for 2 years now. This is his second medication. What would be a signal for a possible change to LEMTRADA?
So a change from any treatment to any treatment, first, would be that there are relapses, there's worsening neurological exam findings, there's new MRI lesions, or a person doesn't tolerate the treatment, or they're having a progressive safety issue. Like JC virus positive, the longer you stay on Tysabri, increasing risk of PML develops, so that would be enough of an issue to say we need to switch to something else, and the medication that's worked best so far in that situation is LEMTRADA.
Thank you, Dr. LaGanke. Dr. LaGanke flew in today from Cullman. You could just set it down. And so we greatly appreciate that he came down. Thanks a lot. Now he needs to fly out, right? Yeah. Thank you.
Thank you very much. Best of luck with everything.
All right, everybody, listen, I never got to tell you. You know what today is? Well, you ain't going to win, so forget that. No, I'm joking. All right, so today is our 42nd program of the year. 42nd. We got 2 more to go. All right? Some of you say, what's the big deal about that, right? It's only 52 weeks in the year. That means that we only did not do programs 7 of those weeks. Okay? That's a lot of work. All right? So we greatly appreciate when you come down to these programs, and that's why we also need you to fill out those seminar evaluation forms, all right? The form that you have, all right? So that way we can know what kind of program we can bring to you the next time. Would anybody like to see us come back and do another program? Great. Glad to hear that. By the way, I forgot to ask the doctor, how many of those black circles were up there? You had that thing flashing around? I know it's a visual thing. Anyway, you know, a lot was discussed here with the symptom management, with exercise, with invisible symptoms, with different medications, with all the different things that you could do for yourself. And again, if you use and you look at our YouTube Learning channel, you can find a video concerning every one of these complementary medications or therapies. So we do hope that you will use that as well. Everybody, again, thank you for coming out today. Thank you for filling out the evaluations. Thanks to our speakers and our volunteers and everybody else. And Don is outside signing books if anybody wants to get a book from him. Thank you again, Genzyme, a Sanofi company, for doing today's funding for today's program. That is all.